I thought I would start out with a little note about new horizons in infertility treatment. Basically, what really are the leading edge new, really shocking new things we're going to do to help infertile couples? Of course, we solved 25 years ago, we solved the problem of male infertility by injecting sperm into the egg. And actually, even when there's no sperm in the ejaculate, we can find sperm 60% of the time in the testes, a very, very small number, but perfectly adequate to inject into the eggs and get a good high pregnancy rate. So the male infertility thing is interesting, but we've solved it from a pragmatic point of view. Now, the problem really is with aging eggs or older women who've run out of eggs. And IVF centers are now finding that at least half their patients the women are over 40. And that's one of the real major causes of this burgeoning infertility epidemic around the world. Let's first talk about stem cells. On any older women, either who's running out of eggs or who has run out of fertile eggs, we're doing a little skin biopsy. We can take a tiny little punch biopsy. It's nothing. It's a 2-minute procedure, nothing to it, under local anesthesia. And we can make stem cells from that. And as we make those stem cells then we can eventually turn into eggs. Now, we've done it successfully in the mouse. And we have baby mice just from their mother's skin biopsy, not from ovaries. We took out the ovaries of these experimental mice. So we know that this works. But now we're just adapting it to the human. And it may take 10 years before we have it completely safety tested and ready for widespread adoption. But I think it's not going to take more than 10 years. We're working on this with every one of our patients who's run out of eggs. We do a skin biopsy. We turn them into stem cells. That's easy. And then we've so far gotten halfway there. We can turn those stem cells into PGCs. That stands for primordial germ cells, which are the cells in the early embryo that eventually become eggs, or if it's in the male, become sperm. So we're halfway there already in the human. We've done tremendous quality and safety control testing on these PGCs, and they really are good. So we're halfway there. But to go the rest of the way from PGC to egg may take 5 years, and then to do total proof of safety might take 10 years. But we know it works because it works on the mouse and with the healthy mice. Furthermore, we're just recreating embryology. We're going from PGC to egg, and that's what happens in the early embryo. So these eggs that we will get from your skin cells will be young eggs. So if we perfect that procedure, these should be extraordinarily fertile eggs, incredibly fertile eggs. So in the future, we might be better off, say, in a 38-year-old woman. That's not so old. But in a 38-year-old, we might be better off in the future doing a skin biopsy than retrieving eggs for IVF. It's just a matter of perfecting how we convert the skin cells into stem cells, into PGCs, into eggs. But theoretically, at least, and it's theoretical, we could get very, very young eggs that would be very fertile. So that's one really fantastic future approach to the biggest problem we face in infertility and IVF now in the current day. But now there's something that is even more spectacular in the sense that we're doing it right now, and it's successful in the human. We call it IVM, or in vitro maturation. Now, it's been talked about for 30 years, but the results haven't been that great. And here's the issue. When we have young women with cancer, we perfected taking out the ovary, freezing the ovary tissue, and then transplanting that ovary tissue back 10 or 20 or 25 years later after she's been cured of her cancer and wants children. So a 45-year-old woman could wind up with a 20-year-old ovary, and she gets pregnant like that. No IVF, nothing. She just ovulates these young eggs, and she gets pregnant and has a baby. And we've had fantastic results of this. We have the only series in the United States, one of the largest in the world. We've been doing that since 1997, freezing ovary tissue from cancer patients, and it really works. But there's something new in this now. I mean, our success rates with frozen ovary transplant are well known and established. But here's what's new. We can take the primordial follicles. We can take the follicles that actually are going to eventually become mature eggs, but aren't yet. And it's shockingly easy, never expected it to be that easy, to mature those eggs into mature eggs in 1 or 2 days that we can then freeze for IVF. And we don't have to do ovary stimulation for that. Now, I can't say that we were the ones that invented that. This really was developed over time by a number of European groups, and finally really perfected by Klaus Andersen's group in Copenhagen, Denmark. But nobody else was doing it. So we followed Klaus Andersen's directions, and we found it's really easy. And we based that on Katsuhiko Hayashi's studies in the mouse. Remember I mentioned we can make eggs in the mouse from skin biopsy. And that was first demonstrated by Katsuhiko Hayashi in Kyushu, Japan. And Dr. Hayashi is our colleague in this whole research project for making eggs in the human from skin biopsies. One of our colleagues, Amanda Clark and Kyle Org, are other colleagues in this four-way study group. But immediately when we use the principles that Hayashi developed with his work in the mouse, we discover that the GV oocytes we readily obtain from ovarian tissue have already gone through all the preliminary phases of development. So with almost any media, no special culture media whatsoever, it's very simple. We get those GV oocytes and we can turn them into normal M2 oocytes, which can be fertilized. And so Klaus Andersen showed that, but Katsuhiko Hayashi gave us the basic science to really understand what we're doing and to make it even simpler and easier than what Andersen is doing. So thanks to Dr. Hayashi from Japan, we're finding it extremely easy to just mature eggs from ovary tissue. So a woman with cancer doesn't have to have ovarian stimulation, which will delay her cancer treatment. We can get just as many good quality eggs just by removing the ovary. We freeze the ovary tissue, but when we dissect the cortex of that ovary tissue, we get all those GV eggs. There must be anywhere from 5 to 90 of these eggs. It's variable depending on the age of the woman. And then we can turn those eggs, 1/3 of them we can turn into normal mature eggs that can be used for IVF. So this is just a spectacular development. Then a third development is little boys with cancer. They're prepubertal. So we can't stimulate them, so to speak, to get sperm, obviously. So what we can do is freeze their ovary tissue. Their testicular, I misspoke, Freudian slip. We can freeze their testicular tissue. And then years later, we can dissolve that tissue, get this spermatogenic stem cells, inject them with ultrasound guidance, which we've already perfected, into the reedy testes of their testes that has no sperm in it because of the cancer treatment. And we get normal spermatogenesis because those stem cells will colonize all of their seminiferous tubules and they start making sperm normally. At least that's what's going to happen in the human. We know that it can happen because we've done the steps of this in animals and it does work. And in humans, we've even perfected injecting into the reedy testes with ultrasound guidance. So it's not a big deal to transfer those spermatogoneal stem cells into the testes. So those are some of the leading edge solutions with in vitro maturation of oocytes, just ovarian tissue freezing and transplantation, and actually conversion of skin cells ultimately into oocytes in women who've run out of eggs because they're getting older. So there are many more new things we're working on. The genetics of spermatogenesis is very important, because if we have men that are just azoospermic and we want them to have normal spermatogenesis, we're going to have to use CRISPR to insert the proper genes that are missing into their cells in order to convert stem cells again into sperm. So there's a huge amount of research that we're doing, and it requires collaboration with other universities, UCLA, University of Kyushu, Pittsburgh University, just to name our major collaborators.